Hello, everyone, and welcome to another episode of the Core Console RX podcast. I'm Mike Corvino. With me, as always, is Cole Swanson, and we have a super special guest today, Steven, aka Paige the PA, via Instagram, coming all the way from Atlanta.
ATL.
What's up, man?
What's going on, guys?
No, not a lot. Thanks for being on here, man. We really appreciate you taking the time to do this.
Hey, it's a pleasure. I was super stoked to hear from you guys and really excited to be a part of it.
We're happy too. So, you're on which rotation right now?
I'm on my second rotation, which is emergency medicine. My first one was internal medicine.
Nice.
So I've got about 2 weeks left of emergency medicine, then it's on to psych.
There you go.
Oh, you're doing psych next?
Yeah.
That's nice. It's gonna be a good one.
It'll be good. It'll be interesting. I was originally supposed to have surgery, but clinical schedule got a little switched up. So I'm doing just like a consult service psych. So it'll be fun.
Nice.
Awesome. How much more time you got? When do you graduate?
I'll graduate in December of this year. So
Awesome.
That's cool,
getting
man.
there. Getting there.
So, tell me because the first time I don't even remember how I stumbled across your page the very first time. You may have even just followed me. I don't know, but I remember seeing your page and seeing you were a student. And is Instagram the only social media that you're on right now, or do you?
So I'm on.
everywhere?
I started on Instagram. Yeah,
Gotcha.
I think that was like where I really started to let it take off. Just because I've always been into like photography and pictures, and I wasn't a huge fan of Facebook, just with all the commentary that's out there.
Yeah.
So I just really started with Instagram and just kind of evolved from there.
Nice. So, I'll see like a lot of these like physicians who are like, been doing it for a minute and they pay off to get followers and stuff. But so you're still in school, still going through rotations. So you're obviously working a ridiculous amount of hours, and you've been doing this how long? Like, what did you say, 4, 5 months, 2 months?
I think it started like October, like September, October.
Really?
You got like
year,
8,000 followers on there already. See, you're doing something right, man. You got something to say that people like. That's awesome.
There's not a ton of PAs out there on social media. So I think it's a pretty new market for PAs. I mean, PA is a pretty new profession. We just turned 50 last year. So, I thought it was a cool way to put the message out there and start doing some advocacy and some education and just kind of show some perspective of what it's like being a PA student.
Awesome.
Yeah.
Well, there's people interested for sure. Yeah, there's been PA schools popping up all over here. I mean, it started out with like 2 for a long time, and they're coming. So it's definitely a growing profession.
Yeah, the demand for like nurse practitioners and PAs is just through the roof right now.
Right.
So it's a nice little gap, and there's a huge opportunity for us to get in there and fill some education and, pick up some of the slack with all the healthcare demands that our country has. So
Yeah. Why,
it's
why
cool.
do
It's
you
a cool
think
time to be a PA.
Why do you think it's growing? Where's the need coming from in like a day-to-day clinic basis? What do you think?
I think it's more just like geographical. You keep hearing about the physician shortage that's been going on for how many years, and PAs are just a really important provider that can fill a lot of the roles that physicians in like rural areas can't. You hear these like areas that have one doc for how many thousands of people just in these rural towns. And so you get PAs that you can get trained in a couple of years, and, they have a pretty full scope of practice depending on which doc they work for. And so you can throw a PA and they can act, mostly as like what a doc would do.
Yeah, very autonomous.
Absolutely.
Yeah.
That's cool, man. How did you decide, like, were you thinking about med school originally, or have you always been focused on being a PA, or what was kind of your...
I got my undergrad in music.
Really?
To be totally fair.
That's awesome.
I was really into performing in the arts, and I got my degree in music and theater. And I just kind of got caught up in the stress of always having to like market yourself, and there's a ton of politics, and it's like one of those things that you have to be fully committed, like in New York or Chicago, working 3 day jobs while you audition during the weekends or whatever. And it just burned out, and it felt just very like self-serving. I wanted to do something a little more, humanitarian, something that was not focused on myself, but like helping other people.
Yeah.
And so I just kind of fell into the medical stuff. My brother was doing his wilderness EMT. My best friend was a phlebotomist. Her sister was a nurse. So just kind of getting hit at healthcare stuff from all angles. And I've always been interested into it. Like I remember like you're like in middle school or like high school where they call like whatever, like first response team to the cafeteria.
Mhm.
Yeah.
Like they call it
EMF.
overhead, and like you see like one kid like run out of the classroom. And you always like, what's going on? Like what happened in the cafeteria? I've always kind of been interested in that, but I never really pursued it. So once I was toward the end of college, I was like, man, I got to do something else for a while. So, I graduated, and like the next weekend I started an EMT course and just like fell in love with it.
Awesome. So you did EMT first?
Yeah, that was like my first introduction into it. And then from there, I just, I kept getting more interested and started doing more research. And I didn't really know what I wanted to do, but I knew I wanted to be in the medical field. And so I just started taking all the prereqs for med school because I knew that that would kind of be all encompassing. And if I had all those, I could probably go any way I wanted to if I decided not to do med school. And so I was on the med school track, and then I found out about PAs and what they do. And I was like, man, if I could go through PA school in like 2-3 years, come out with half the debt, accomplish all the things that I want to do in medicine as a PA, like, man, I don't need to go to med school.
Yeah, for sure.
So that's kind of it in a nutshell.
No, that's awesome, man. Do you feel like, because I know for me, like one of the main things that was kind of like my deciding factor, I guess, for going to pharmacy school was because I was kind of originally thinking med school as well. Like I was pretty set on med school when I was in undergrad. And then like the mid junior year, I guess, is when I really switched tracks. And for me, it was the idea that I could kind of jump into a bunch of different roles very easily. Whereas like in medicine, you still can jump in different things, but if you're a cardiologist, you can't get up one morning and go, you know what I'm gonna do? I'm gonna do pulmonology. See you guys later. Like you're very specialized. And they have so much training in that area, which is excellent. But you're kind of doing that forever. And I'm the kind of person that gets bored really easily. So for me, pharmacy was like I can jump into like 15 different things. I mean, granted, you have to have residencies and things for certain jobs, but you can do a lot. Did you feel like that with PAs at all? Because I feel like that would be a little bit easier for you guys to maneuver and try out different stuff more so than an attending, I guess.
100%. When I found out that PAs could work in multiple fields and switch without having to do a residency or anything like that, I was like, that's it.
Yeah.
I'm the same as you. Like that's why I love working in the ER, because you can walk into one patient and have like an earache. The next patient would be like a cardiac arrest. Your next patient's gonna be a drug overdose. It's like, it's very good for people with ADD. It's just kind of like boom, 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 all over the place. So PA was like, that was actually one of the big selling points. And the term we use is lateral mobility. Mm-hmm. We have this lateral mobility. So say once we graduate, we're basically general practitioners, just generalists. And then from there, we kind of get on the job training in whatever specialty we decide to do. And, there's people that work multiple specialties at a time. I've got one professor who's like working IR, pediatrics and like critical care. And then he's got a central line business on the side. And so
wow,
that's like one of the huge perks of PAs. Like it's very, very flexible in what you can do. So like something for like you or me that, have a ton of different interests and like things that we want to learn about. It was just the perfect choice.
Yeah, that's awesome, man.
That's great. Yeah, my fiance Anna's about to graduate PA school, and that's one of the big things that she says all the time is that not only can you move laterally and go to different jobs and specialties, but it's very much encouraged and very commonplace to work as a PA in one setting for 3 or 4 or 5 years and then just bounce over to something else, and it's really easy. So that's awesome.
For sure. But, for people that like having that continuity and just want to focus and specialize and research the heck out of one thing and be experts, like med school is definitely the route.
Yeah, absolutely. And that's the thing. Like, and I never want to sound like I'm knocking it, because I have so much respect for the amount of knowledge you have to be, say, a cardiologist, that it's mind blowing to me that someone has studied it that in depth. But yeah, I do definitely like the flexibility, and I kind of assumed that was the case with you with the PA thing. I just wanted to get your take on it. What about kind of going back to the social media thing? So there's a lot of stigma with social media, especially in my experience. And Cole, I'm sure you went through the same things. We, in a couple months we'll have graduated from the same school. It's one of those things that a lot of the professors, the faculty, it really encouraged students to get rid of their social media, to block people, to whatever they need to do to not have any kind of like I guess presence on social media because they don't want to like make the school look bad or get the kids in trouble, whatever the case may be. What do you think about that? Like, how do you see that playing out 10 years from now when us horrible millennials take over?
It's a slippery slope for sure. I mean, anything you put on the internet, theoretically is there forever.
Yeah.
And so when you're going to an institution and say your social media has their name, branded all over it, I mean, unless you have a very clear like clause in your bio saying, my opinions are not reflective of any institution I'm affiliated with, it's like you're kind of branding that institution. So I can get their angle, but at the same time, there's the freedom of speech and the freedom to express yourself and your opinions. So I'm not going to act like I'm an expert. I'm still trying to navigate it. Luckily, I haven't had too many issues, but I've had a couple of problems just with internet trolls that I've actually had to talk to my program director about a couple times, but she's always been super supportive. So it's a slippery slope for sure.
Yeah, that's good. But I mean, social media is like anything else. It can be good and bad, and people can mess themselves up by putting stuff they shouldn't put on there. And that's just the way it is. Like you could do that with a newspaper probably. So, and
that's the thing. It's also a matter of perspective. You could post something with one intention or one idea, but someone misinterprets it and takes it a completely different way. And, slippery slope for sure.
Yeah. I'm going to give my take on it real quick, just because I want this on the record.
Do it.
I truly believe that this, as we kind of take over things and our generation sort of like goes forward. I think social media, because that's what we've always had and what we've kind of grew up with, whereas the generation above us didn't really have that, and it's all new and world ending for them. I feel like social media is going to actually end up being something that healthcare professionals can use to brand themselves on purpose, because institutions are actually going to see that as a way of bringing in money and patients and students and things like that. And I truly believe that like eventually it's going to be like medical professionals, and again, professionals, I'm not saying idiots. I don't think the the Kardashians of the medical world are going to take over, and that's what I'm saying, actual professionals, but branding themselves in a way that gets a big following. Because if you think about it, you have 7,000 8,000 followers. A lot of them are probably PAs, or at least people interested in PA school. If that university or that hospital brings you in as one of the PAs and you're constantly talking about them, that's 8,000 people that they weren't in front of before. I mean, they may have known about the school, but I mean, that's, to me, I mean, it's like huge advertising and huge solid publicity. Again, it's all relative, because if you're a jerk about it, then obviously it's not going to work out. But people who are doing it with good intentions and just to promote medicine, I feel like social media is going to be a huge tool here in the next 10 years.
No, I think that's reasonable. And you obviously promote your school's brand well. And back to a medical professional promoting themselves, with the push for quality metrics, especially for Medicare. We could do a whole podcast on Medicare and the new quality metrics coming out for insurance companies, especially with physicians. Meeting those metrics is like, it's now coming in like 2019 and 2020. It'll follow them. So it's not just associated with the institution, it's associated with the actual medical professional. So if they are meeting the quality metrics, they have a good record and a good quote unquote score, they can brand themselves and potentially get opportunities that way. And they can use social media for that and other avenues. But yeah, it's very interesting.
Oh,
and I could be completely wrong, but if I'm not, I just really want to be like, yo, check this out. When I was 29, I said this was going to happen, and look what happened. Boom, called it.
It's official now. It's on the
officially
podcast.
On the podcast, at least until iTunes kicks us off.
Right.
And I mean, like, if you look at some of the people on Instagram, like some of the dermatologists and surgeons, like they do brand their practice.
Oh, 100%.
And have procedures and all sorts of crazy things.
The billboards.
you have to make sure that you're abiding by HIPAA, and it's a very fine line. So, as I kind of go through this journey, and I'm still super new, just trying to like move slowly, not grow too fast, and just be very careful and, choose what I post wisely. And it's hard because you post something now that might have consequences 5 years from now. And so it's a game.
Gotta be careful.
But it's a super important tool. And I think a lot of the people that follow me are like pre-med or pre-PA or pre-nursing, or people in undergrad who are trying to figure out which route they want to go. Mm-hmm. And so a lot of people have heard about PAs and heard some of the buzz. I'm sure Cole, like with your wife, I'm sure she's talked about it a lot. It's a really hot career, and a lot of people want to get into it. And it's super competitive. The last time I looked at the statistics, it's almost more competitive, if not more competitive, getting to PA school than it is medical school.
I think it is more
because
competitive.
The demand is so high.
Yeah, I think that makes sense. My little brother's pre-PA, and he's about to finish his sophomore year. And I'm telling him, you got to get the hours, you got to get the patient contact hours, because they look at that. You got to get extracurriculars, you got to have a good GPA, because it's super competitive for sure.
And you have to really differentiate yourself nowadays. I mean, it's easy. Well, it's not easy, but a lot of people can get good GPA, good GRE, good healthcare hours. So you really have to be able to do volunteer things, do different side projects. But a lot of what I do on social media is answering questions from pre-PAs, like, hey, like, what's the best way to prepare for an interview? Like, hey, what's good healthcare experience I can get? Yada, yada, yada. So it's a really important and prominent educational tool, especially because we're such a connected generation. Mm-hmm. And so, I admittedly, when I was looking into it, I was on YouTube all the time, watching people's videos, how am I going to get an edge? How am I going to get better? Because like, I want to get in. And so I think a lot of people are using YouTube, Instagram, Facebook, not just for like the social aspect, but for actually learning and trying to figure out how to navigate, how to get into these schools. So it's a kind of a cool opportunity to act as a mentor. And I didn't really think that was going to happen, but as soon as I got into it, is just people asking questions all the time. And so it's kind of cool to lend your 2 cents. And I've helped a few people get in, which is cool. It's like a great feeling to see people be successful.
Awesome.
And that's the thing too, man, like going back to like intent on people using social media and like whether or not it's a good thing or not. Like, you're in school, you're a super busy guy, like you got all this stuff going on, and I'll go through, I'll see like 200 comments on one of your posts, and I feel like you answer every single one of them like back. Like, I mean, that's awesome. Like, you clearly enjoy like talking to people, especially like people that look up to you, and like they're under, 21-year-old kids that are looking at going to PA school, and now they got a good influence to kind of go by. I just feel like that's the best way possible to use social media. So I think it's you're a solid example of that. And the content you put is interesting too. Like I was telling you, when we were talking before we started recording, you were putting that video up of you doing the sutures, and like nobody wants a pill pusher suturing them, but I was still just like, yeah, I need to learn that. That's awesome. Like it was super cool. I mean, stuff like that people don't think about, but it's not just you taking a picture of your food. It's you actually showing the world of medicine. It's cool. It's good.
I appreciate it. It's a cool tool to be able to do something like that. Like, I don't know if you saw it, like my buddy Nick and we did like an Instagram live session the other night, and that's all we did. Like, he's a cardiac intervention specialist, and so he does like some suturing and has some like cool trips and tips that he's sharing with me. And so we just went on live, and we had a lot of suture pads set up. We were just practicing. It was cool.
Yeah, that's awesome.
I mean, that's the thing. I always make the joke that I'm like super introverted person, and so social media is sort of my way to be social without actually having to be social.
I gotcha. No, it's good, man. You're killing it, especially for such a short amount of time. Like, I think you need to slow down just so that I don't feel bad about myself.
Yeah, you can't grow too fast. It's something someone told me. You have to grow, slowly, otherwise you're gonna get in over your head. But yeah, I was totally surprised and overwhelmed at the response that I've gotten. But it's awesome. And then one of the other really cool things is meeting, like you and Cole. It's awesome networking opportunity.
Yeah, I agree.
And people and talk to people that you normally wouldn't be able to.
Exactly. Like, we're in different states. I've met the guy, Adam Martin, that goes by the Fit Pharmacist on Instagram. I saw him whenever I first started on there, and I was like, oh, wow, this pharmacist got 12,000 followers, whatever it was. That's pretty cool. And then, like, 8 months later, the dude's flying in an airplane to come stay at my house. I mean, it's crazy. He's from Pennsylvania, and same with Rich from RX Radio in Miami.
He came up.
Yeah, the first time I met him was me picking him up from his like Airbnb, and he was like, "What's up?" Like, it's a totally different, just a different world. You get to meet all these people and network with these professionals you never would unless you were like going to a conference or something. And everybody's all burned out from listening to CE all day, and then, it's a very relaxed environment to meet people who are trying to do innovative stuff in the world of medicine. It's cool. I like it. I'm addicted to it.
The good thing about being in Charleston is that everybody wants to come here, so we don't have to go anywhere. They're just gonna, meet us here, Miami, Pennsylvania, wherever. Yeah. But we would.
I might try to go to Miami actually next month for this conference.
Well, awesome.
To meet him down there.
Miami's
meet Rich down
awesome.
there. We'll see.
Yeah.
But yeah, that's cool, man. So what's your game plan afterwards? Do you have a specialty that you're kind of thinking about, or are you gonna keep doing the page to PA full time and go on the road?
Man, that's the $1 million question. I don't know. I mean, they say in clinicals that you find out what you don't want to do, and I'm definitely starting to learn that a little bit. I have an interest in ICU medicine, critical care, and also surgery, but I haven't had those rotations yet, so I can't really speak knowledgeably about it or really tell you if that's something I want to do. My background obviously is in emergency medicine. I did that for I think 5 or 6 years, so I know that, and it's comfortable and it's familiar. But again, not sure if I want to do something else. In terms of page to PA, I changed my mind with what I want to do with it daily. Sometimes I just want to make it like a general like PA resource. Sometimes I just want to bury it and not worry about it, just because social media can get crazy sometimes. It's just, the way people treat each other on there and some of the things people say. And, it can be really nasty. There's some, really cruel people out there. And so I just don't like being a part of that. So it's very like multidimensional, but, I'm not sure. We'll see what happens after clinicals. Ask me again in about 7 or 8 months.
Yeah, you got plenty more rotations to go through before you have to make that decision. So
for sure.
Cool.
But that's a cool thing. I can kind of go wherever and do whatever I'd like. That's the great thing about being PA.
Yeah.
Heck yeah. The other thing too that I like is, and this isn't just in social media, but kind of in general, I feel like there's every healthcare professional has its like little clique, right? So like pharmacy sticks with pharmacy a lot of times. PAs, I'm sure, stick with PAs, and MDs stick with MD, and like they're very, especially like outside of being on rounds, like a lot of times it's very cliquey, and I see that a lot on social media too. You can kind of see it in there where like most people that are following me are PharmD majors or like or current pharmacists or whatever, and what I liked is like like as soon as I contacted you, it was like, oh yeah, man, let's do it. Like, cool, that'd be awesome. PA, PharmD, like working on stuff. Like, let's get a podcast going. You were just super open about that. Do you feel like promoting interprofessionalism is important?
Oh, 100%.
Yeah.
Like when I saw what you guys were doing, I was just so on board with it. I'm a huge advocate for interprofessionalism and teamwork. And I mean, it's just, healthcare is 100% about taking care of the patient, and it doesn't matter if you're a doctor, if you're a janitor, health, it doesn't matter what you do. Like
exactly.
We all have the same goal, right? Yeah. We have different, areas of expertise, but we're all there to do the same thing. And so I just don't view it as a hierarchy at all. Mm-hmm. And so even on Instagram, like that's one of my favorite things probably is just being able to interact with doctors and nurse practitioners and CNAs and just like jobs I've never even heard of.
Yeah.
Partly for the educational, but just like the camaraderie, and you get a different perspective, like seeing what you guys do. Like I've learned so much about pharmacy, and honestly, like seeing you guys like go out into the community and do like diabetes education, like this is all stuff that I had no idea that pharmacists really did. Like when I think of pharmacists, I'm just like, the guy in Walmart, like just passing out drugs.
Yeah.
And that's just because I haven't really been exposed to many pharmacists. So this is like an incredible opportunity to see more about what you guys do and how you guys kind of go through and do things more than just, doling out medications. You're like super integral in patient education and, just the whole list of things. And so being able to know this, like when next time I have an interaction with the pharmacist, I can be like, hey, I know you guys sometimes do this. And, it can just lead to places that will provide the patients with better care ultimately. And like, that's the name of the game.
For
right?
sure. Yeah, use
100%.
us, utilize us, ask us questions.
And like
Pharmacists.
vice versa. I mean,
Yeah,
you guys kind of hear like perspective of a PA student, like maybe that'll shape your perspective on
absolutely.
Mike. I know you like you're an adjunct professor, and so maybe there's some stuff we could talk about that. My experience with pharmacology in PA school has been rough, and I'm always happy to share, my opinion and my experience with that, and how maybe you could make it, better when you're teaching your students.
Yeah, for sure. I'm definitely gonna be picking your brain about that because I'm getting started here in a couple weeks, like officially. Like this is the first class the school's had, like it's brand new, and I'm literally the only non-PA MD that's there. Like when they brought me in, I was so excited because I didn't think there was a chance in heck they were actually gonna let me teach this class. And not only that, but then I really kind of anticipated them being like, well, this, he's 20 years younger than we are, and there's just no way like we can take him seriously. And I was just kind of like really watching what I said because I don't want to offend anybody. I mean, one, I have a ton of respect for the amount of clinical knowledge somebody who's been a PA for 20 years has, and two, I just I'm the new guy. I don't want to like step on toes or come off as arrogant. And every PA that I interacted with there is like the nicest person I've ever met in my life, and has been. I made a couple comments about like they had a test question circled as the right answer, and I was like, I don't know if I'd put that there, and I was like, oh shoot, what am I shouldn't open my mouth. And he's like, yeah, man, that's why we brought you in here. And I mean, it's such a cool group. I mean, I was excited and took this on really honestly just for the networking and to get the experience with other healthcare professionals on a daily basis, and the students too, because I want to give my perspective as a pharmacist in the evidence-based medicine to the students so that they have that directly going in, and then they can take evidence-based medicine into their clinic. I mean, you guys are the ones writing the prescriptions. I'm not. And so pharmacists can know all the evidence-based medicine they want, but if they don't have good relationships where the providers trust them, then what's the point? And so I think that the CSU thing is something I'm extremely excited about just because it's just such a good opportunity that I am still kind of shocked that I get to do. But yeah, very excited about that
that's
starting.
Great. One of my favorite lectures was actually one of our PharmDs who came in and through our didactic year, the way our school does it was we break it up into like organ-based system modules. So we'll have like cardiology, pulmonology, psychology or psychiatry, whatever. And so he'll come in during each module and just kind of go through, the core meds for each organ system that we're studying. And he's just like this really smart dude and like understands the physiology and knows what we need to know as, just first line clinicians.
Right.
Obviously like a smart dude who can like give you studies and trials for everything he talks about. But presents it to us like in a very matter of fact, like, these are your gold rules for COPD. Like, this is what you need to do. This is what you need to know without completely just overwhelming us, which most of us feel when we're studying pharmacology.
I mean, well, you guys have so much information coming at. I mean, it's a lot of school and a lot of information to slam into 2.5 years. It's crazy. Like trying to like write the curriculum for the pharmacology class that I'm teaching was like insanity to me. I was like, there's so much information. I'm gonna have to talk like an auctioneer to get all this stuff out. I mean, you guys have a lot of stuff to memorize in a really short amount of time. I mean, I definitely have a lot of respect for it, for sure, because it would be rough.
Yeah, they call it med school on crack.
Yeah, there you go.
Because when we walk into a room and see a patient, we're essentially expected to see, treat, diagnose, and care for a patient just the same as a physician would. Obviously, we don't go nearly as in depth as physicians do, or like y'all do. But we touch, a big chunk of medicine. So yeah, you got to talk fast and pay attention.
No, I mean, you guys are. I mean, like I said, I have a ton of respect for what PAs do. I mean, you guys are. I've seen some PAs that are like, I'm like, gosh, this dude's a rock star. I mean, yeah, you guys are doing big things. But cool, man. So you want to jump into this patient case? And
yes, we will actually talk about medicine on this podcast at some point.
No, it's cool. That's the best thing about the podcast is we don't have a set time.
We can do whatever we want. Yeah.
All right. So the patient case today.
Well, can I introduce it?
Oh yeah, that's right. Do your history.
I have a little history lesson.
That's right.
All right. Quickly.
Cole's our new. It's a historian. It's this new segment we call Cole the Historian.
History with Cole.
Yeah,
it's fun.
We're still working on the title, but after that,
all we need is a time machine. We'll be good.
You need some theme music.
We do. I might insert some theme music here. We'll say.
Okay, pause for music.
Yeah.
Okay, we're good. All right, Mike.
Yes.
Have you ever heard of apoplexy?
Have I ever heard of it?
Yes. It's okay. I hadn't until yesterday.
Don't feel like I have.
That's all right. It's a Greek word.
Okay.
Not anymore is it a condition, but it's a Greek word meaning struck down by violence.
Huh?
And that is the original name for stroke. Coined about 2,400 years ago by none other than Hippocrates, the father of medicine. He called it apoplexy because people would just kind of die, and they didn't know why. They would have paralysis and a change in well-being is what he called it, and then die, and they didn't know why. So they just called it apoplexy for a long time. Till around the mid-1600s, some dude named Jacob Webfer figured out that apoplexy was caused by a brain bleed and could also be caused by a blockage of blood flow to the brain. And that's where they were like, oh, so this is a stroke. But they still didn't call it that. They still called it apoplexy. It wasn't until like 100 years ago, like 1928, when they finally divided it into ischemic stroke and hemorrhagic stroke and coined it cerebrovascular accident, CVA, and finally stopped calling it apoplexy, from what I understand at least. And that is where we get the term stroke. It's actually pretty recent.
That is pretty good.
So there's some trivia for you. This is from Johns Hopkins.
Huh.
Yeah.
Because the one you did on COPD the other day, I was like, where's he finding this stuff?
I can't remember where that one was from. I don't know. I do back it up by some other sources, but this is Johns Hopkins. Yeah. This seems to be pretty well known. So people listening, you may already know this. Yeah, seems legit. It's got Hippocrates in there. It's got to be legit.
It's definitely legit.
So
cool. That was good, man. Thanks.
Awesome.
So the case today is KB, 70-year-old female that presented to the ED at 0700 hours on 1/15, complaining of left-sided weakness. She had she was currently taking Xarelto, and she was also on aspirin 81 milligrams as well. She was feeling normal the night that she went to bed on 1/14, but then it woke at 0400 hours and with slurred speech, left-sided weakness. She denies any kind of headache, blurred vision, fever. She doesn't have any seizure activity. She does have past medical history of AFib and arrhythmia, and she is currently taking Xarelto, like I said, for stroke prevention. She's also on Tylenol because she has minor osteoarthritis. She's on 81 milligram aspirin. She's also taking calcium carbonate, 600 milligrams. She's taking 2 of those every day, along with her vitamin D. She's doing 2,000 units, 2 tablets daily. The B12 daily. She's on metoprolol 25 for rate control for her AFib. And then she was also on an estradiol norethindrone, which is a hormone replacement tablet that they were a little bit concerned about too, because the estradiol component can also promote clots. So basically when she arrived, it was ruled, and I won't go through all this because we're going to post the case.
Yeah, we'll post it to the website for those of you who want to look at it. But if you're in your car or whatever and you can't access it through a website, don't freak out. Don't tune out. We will reference whatever we're specifically talking about. So you're okay. Keep listening.
There you go. So they did rule it as an ischemic stroke, and they actually did do a mechanical thrombectomy. She was not a candidate for TPA because of the Xarelto. They did do mechanical thrombectomy though with stent retriever, and one of there's different ways of kind of going about this, and I'm by no means an expert in this, so I probably shouldn't even address it, but that's okay. The American Heart Association, they basically give it they make the patient a candidate if they meet all of these criteria, and that's the pre-stroke MRS score of either 0 or 1. They have to have a occlusion of the internal carotid artery or the MCA segment 1. They also have to be above 18 years old. They have to have a NIHSS score of 6 or greater, aspect score of greater than 6 or greater, and then they have to be able to start treatment through a groin puncture within 6 hours of symptom onset. So there's several studies that they mentioned in the trials. Mr. Clean, Escape. There was a bunch of them. I like Mr. Clean. That's a cool trial name, so I put that down. But lots of trials. They quoted like 10 of them that showed benefit.
So basically, big things with this lady. She's 70 years old, so she's elderly. She's coming in with symptoms of an acute ischemic stroke. She has an acute ischemic stroke. History of AFib. So that's a big thing.
That's the big takeaways we're going to focus on.
So Steve, if you're seeing somebody like this present to the ED, so we're looking at her on discharge. We're looking over her chart before she's discharged. But when she presents, if you see her, what's the first thing you're doing? What are you thinking?
Sure. So I got to admit, when I first read just the first subjective paragraph, I just thought clot. This lady's a walking clot, whether it's in her lungs or legs or carotids or brain, just because she has all these risk factors, AFib, mechanical valve replacement. She's had, and that was within a couple weeks prior. She's taken estrogen or estradiol. She's taken hormones. She's a smoking history. I mean, diabetes. She just got all these risk factors that she's a clot waiting to happen. And so as I kept reading through, I was just kind of wondering how it was going to manifest. But the first thing you said was left side weakness. And so when someone comes in with any sort of neurological complaint, like in the ER setting, at least, you want to figure out what's going to kill them first. Hemorrhagic stroke, ischemic stroke. Is she hypoglycemic? You kind of go through your DDX and you just knock off each one. But, she presented with, unilateral weakness. I don't know if she had slurred speech or if she had any sort of facial droop, but, there's all these big stroke scores that I admittedly am not super familiar with. I haven't dug too deep into neurology. But it sounds like, she was worked up pretty quick and found to have an ischemic stroke. And so you kind of got to act quickly because brain is tissue, time is tissue.
Right.
And so, with a stroke, you got to figure out, is it ischemic or is it hemorrhagic? And then if it is ischemic, is she a candidate for thrombolytics or a clot removal like we had in this case, or what have you? And so that's kind of like the process that we go through just on the front end. She's taking all these meds. I mean, we'll get to that later on, but, in the emergency setting, we just want to see, what's going to kill them first. How do we stop it?
Right. So for you, before we know it's an ischemic stroke and she's coming in this way with the left-sided weakness, clearly some sort of stroke, are you automatically giving her aspirin and then moving on, or are you waiting to find out if it's ischemic or hemorrhagic?
I mean, just anecdotally, I'd probably give her some aspirin.
Yeah, I think that's pretty standard.
I mean, like for a chest pain patient, like, I'm not sure if you guys heard the MONA, the mnemonic for like morphine, oxygen, nitrates, aspirin. Aspirin's the only one proven to decrease mortality.
Yep.
And so in her case, I don't think an aspirin's going to hurt her. So, anecdotally, I'd probably give her an aspirin.
No, I agree. I mean, that's if they come in, they're giving them an aspirin, and whatever else happens after that just kind of happens.
So one of the things after they kind of got her stable, they started her on 325 milligrams of aspirin instead of 81 milligrams. And they were going to do that until they could start the warfarin. They stopped the Xarelto and switched over to warfarin. And they did that because they thought the Xarelto was obviously ineffective because she had a stroke. So one thing to consider, and again, not that that's wrong. It's probably the right thing and probably what a lot of people would agree to do. But one of the things to consider is the patient has AFib. And so if we look at the study, the Rocket AF study that Xarelto was compared directly to warfarin, and showed non-inferiority and all that. One of the caveats to that study is apparently the devices that they were using to register INRs were actually recalled at some point after the study. And so there was some discrepancy there about whether or not they were actually dosing the warfarins too high and people were becoming over anticoagulated. And if that's the case, we, obviously may have tweaked the results a little bit. Now, they went back and they've done kind of reassessments and things like that. And they say, no, everything's good. The data's good. But I don't know. I still feel there's something big like that. They can kind of put a damper on the data a little bit. But the other thing to consider is that Eliquis, apixaban, is actually, it's been compared to warfarin as well in the Aristotle trial, and it was actually superior to warfarin in patients with AFib, and it had less side effects, I believe it was intracranial hemorrhage, I believe.
Yeah, so they had lower rates of bleeding, and they had a greater reduction in the rate of stroke than warfarin, which, for the most part, the rest of them are just non-inferior pretty much across the board. So that's not too bad.
It'd be something to consider too. So if the patient, for instance, was absolutely not coming back for INR follow-ups, you knew there was no way you're going to be able to follow her INR, Eliquis would probably be my recommendation to switch to. Just it's got a little bit better data, and the only thing is that it is twice a day, so we have to see how she'd be as far as adherence. But she's taking the metoprolol twice a day, so I think it'd be okay.
Right, I think she can handle it. If it
one of the things we were go ahead.
If it's covered by insurance, maybe they preferred Xarelto, and now she can't afford it, so they want to do warfarin. But if it is, that's definitely an option. What were you gonna say?
Just we were talking earlier. One of the things I'm just kind of thinking in the back of my head is if she just had a stroke, how's it affecting her cognitive behavior? Is she still going to be, able to take her meds? One of the big things we see in this population is polypharmacy. Geriatrics, sometimes they don't know what pills they're taking. They've got so many. And so a lot of times we get overdoses or patients with altered mental status, and we have no idea why. And it's kind of hard to really go down that list of differential diagnosis until we get that med list and see, oh man, this person's taking 15 medications. Okay.
Right.
And I think that's part of the reason the Beers criteria was developed, is to start knocking off medications that patients in this age range don't necessarily need to be on. And so what I'm thinking is, if we give her one of these NOACs or DOACs, what do you call them? Say they do polypharmacy, how are we going to reverse that? I know there's been some controversy in trials about, Anexa?
Yeah, the reversal agents, you mean?
Yeah, and so obviously, like with someone with warfarin overdose, and popping some vitamin K or what have you.
Yeah.
If someone's like super over anticoagulated and they're hemorrhaging, what's the risk to benefit ratio if we're giving them,
right.
A warfarin versus a rivaroxaban or what have you.
That's always a consideration, and they have a way that you can kind of gauge the risk of bleeding. It's called the Has-Bled score. It doesn't really direct you in any particular way, but you can see what their risk of bleeding is overall. I mean, she's doing okay, relatively speaking. I mean, she does have she really doesn't have much as far as past medical history goes. She doesn't even have hypertension. So that that's positive in terms of her bleed risk. Is it reasonable to assume that Eliquis, based on its half-life, would probably reverse faster than a rivaroxaban as far as anticoagulation wearing off? This is not evidence-based. This is cold thinking.
That I don't know.
Yeah, I don't think you can take that to the bank, but that's just me thinking about it.
Because, I mean, as soon as you start that and Xarelto, you're immediately anticoagulated. So I don't know that it would be quicker to reverse it. But I don't know that one. We'll have to ask.
Yeah,
I'll ask somebody who's much smarter than me about that one.
And dabigatran does have a reversal agent that came out. I think it's...
Digibine.
Yeah.
I believe is what it's called.
The generic, like, Idea Usizumab or something. I don't know.
Yeah. I'm not even going to try.
Anyways,
I don't remember.
It has
one of the MABs, one of the monoclonal antibodies.
Right, but edoxaban, rivaroxaban, and Eliquis, apixaban don't have reversal agents.
Yeah.
And so my question for you guys is, when we get to this patient and we're doing, their med rec and, getting ready for them to go home, what's your role, and how do you kind of determine what the patient gets? Like, does the physician consult you? Do you guys have much say? Is like, hey, this person should probably be on warfarin versus also, like, what's your role in, I guess,
right. You go ahead.
No, go ahead.
So in my experience, they would, if they have a pharmacist on the team, which I think is great to have, by the way, then
job security.
They'll generally ask. A lot of times cards might be involved. So if cards is involved, they usually handle that. But if it's like a family medicine team who's handling it, or if you are the pharmacist on the cards team, then they might ask you. And so I would look at this patient and say, okay, so it's between a NOAC and warfarin. Things to consider with warfarin: they're going to have follow-up, very frequent follow-up, potentially every month, depending. If you can't get their INRs consistent, then they might have to follow up like every week or something with someone outpatient. So that's a consideration. So you'd have to say, okay, does she have transportation? Does she have good support from her family who could get her there? There's also dietary considerations. What's her diet like? Is she going to be able to take warfarin and have steady INRs? Warfarin is cheap, so that's good. So if money was an issue, then that's a consideration there. With the NOACs, if there's no way for her to get it paid for, then that's probably not an option for her. But if she can, it's simple. There's no follow-up. Some doctors want to follow up like in the first few months just to make sure that their hemoglobin and hematocrit's okay, their creatinine clearance is okay, and they're not having like AKI or something like that, or they're not having some type of bleed, so they'll monitor that sort of thing. But otherwise, it's pretty low maintenance. You just take it and you're good to go. So that is brought up a lot about the fact that there's no reversal agents. So that is a consideration. But if you don't think that I don't particularly put her at a super high risk of a bleed, just relatively speaking. So I would feel comfortable and probably recommend a NOAC for her if that was going to be paid for by your insurance.
Yeah, and I think too, as far as the pharmacist's role in this particular patient, as she's leaving the hospital, I would say that it would be very good if the pharmacist would actually sit down with the patient and spend the time going over their meds. Nurses are really good about that as well. And then if we're worried about polypharmacy, so if, like, let's say she has Xarelto refills left on her profile at the pharmacy she fills at, or she's not all the way there as far as cognitive function, making sure that the pharmacist calls and speaks to the pharmacist at the dispensing pharmacy and has them cancel the prescriptions and kind of go that extra mile to make sure, because one of the big misconceptions is that the pharmacists at the actual dispensing pharmacy are just going to be able to kind of read the play. But with they're, with the heavy patient volume, a lot of times this stuff gets overlooked. When patients are coming in, maybe they don't even see the patient. And two, it's hard to be able to know what was going on, or, we don't see labs. We don't see anything. We don't see anything that was going on or why things were stopped. And so the patient a lot of times doesn't remember. So having that contact is I think pretty important, even if it's pharmacist to pharmacist, just to you're going to be filling the prescription. You're going to be counseling them again when you give them this new prescription. Here's what's going on, just to kind of fill them in would be, it's something that very, very, very rarely happens, but it would be great if it did more.
And so not only on just our personal opinions, I believe it's the CHEST guidelines came out recently, and I'm pretty sure it was for VTE, but they're recommending DOACs over warfarin for treatment of DVT. And I think in general, it's kind of trending that way to prefer DOACs over warfarin. They haven't come out explicitly and said, yeah, in AFib, you definitely want to do DOACs over warfarin, but for VTE they have, and I think that eventually the data will point them in that direction.
And this is totally I'm going to do a 2-second side note, but just for if there's students listening or whatever, one of the most important things as a pharmacist when you're speaking to a provider is to be respectful. I've seen preceptors, I've seen pharmacists who have this idea that I'm a PharmD, I'm the drug expert, you better listen to me. It's like, well, it's their license that they're prescribing, and it's just so mind-blowing that people can have that kind of arrogance coming out, and no one's going to respond to that. I wouldn't respond to somebody like that if they came to me. And I've worked with one pharmacist, one preceptor that I had that was the exact opposite. He's a young guy. He's probably the youngest guy on the team. He'll probably be on the podcast here in a few weeks. And literally, I've never seen more respect from attendings than I've ever seen towards him. I mean, they would go to him for everything. The residents, they went to him for everything because he's such a humble guy and always approaches the situation that way. And he's proven himself because now they've gotten to know him, and now they go to him for everything. There's a respect there. But I feel like that's an issue sometimes as pharmacists because we're not quote unquote healthcare providers. We get crapped on sometimes, and so there's this feeling of I gotta show you I'm a PharmD and prove my worth and blah blah blah. And I think that's just a horrible way to going about it.
Agreed.
So
I think humility in medicine is undervalued for sure.
The what?
I think humility in medicine is highly undervalued.
100%.
That is an interprofessional skill. Is pride. I would say. It's across all professions. There's prideful healthcare professionals.
Mm-hmm. For sure.
I mean, that, just coming back to like just the core concept of, it's a team. Like we all have our own like specialties. Like if I have a question about a medicine, like I'm going to go to you guys, and like I expect you guys to, know it all, because that's your bread and butter. That's what you do every day. Like, who else am I going to go to? Like, what do I know? Like, I can get up on the up to date or Dynamed and look at a trial, but this is what you guys live, sleep, and breathe. So, there's no way I'm going to sit here and try to tell you how to do your job. I'm going to come to you guys with all my questions.
Hey, Dynamed is good though. So if you don't have access to one of us, Dynamed's trustworthy.
Dynamed's pretty solid. I like up to date too, but just don't tell anybody. But yeah, no, that's cool. And the same thing with you guys. Like, yeah, the idea of, it's like, oh, I can't believe they don't just do this with the meds. And it's like, okay, well, you go diagnose that person. Let me know what you come up with.
Yeah, let's see how your physical exam turns out, PharmD,
I think
with meds, so much of it is just like point and click. The dose is already in there. Like everything's all like, at least in hospital systems, a lot of it's just like, here's your propranolol, here's your insulin. It's just like all point and click. And so, a lot of that stuff's taken care of for us. And so.
So moving forward, people are hopefully not tuning us out by now, but now that we're just kind of rapping a little bit, but that's pretty fun. So as far as her AFib and just controlling her heart rate right now is controlled. We used to push the heart rate down to 80 in AFib, but then the Race 2 trial came out, showed there wasn't necessarily a benefit in that unless they have symptomatic AFib. So currently we typically treat patients with AFib to a heart rate goal of 110, and if they're still having symptoms, then we push it down to 80 at that point.
Yeah.
Good.
That's the Race 2. And the Race 1, just for your knowledge, showed that rate control is essentially non-inferior to rhythm control. Controlling the rhythm, a lot of the drugs involved in that have a lot of adverse side effects, where some of the rate control ones don't as much. So generally these days, people are first line. They're going to try rate control over rhythm control.
Yeah, and the Affirm trial was the other one that compared rate to rhythm, and Affirm is one of those things that you're always taught. At least we were taught in school. Okay, Affirm proves that rate is non-inferior to rhythm and has less side effects and is better. There is definitely some controversy. I think there was a study that came out. I believe it was called Reaffirm, and it was kind of like a second look at the Affirm trial, but it was saying that there was saying that basically maybe some of the effect, like the patients that were in the rhythm control wouldn't actually qualify in a real setting for rhythm control. So maybe if we had saved the rhythm control for the more sick patients, we actually would have seen the benefit. That's a very, very way overly simplistic way of putting it, but I think it kind of goes back to what we always talk about is looking at it as a patient-specific thing and not just saying, yep, AFib, cool, control the rate, because we don't need to control the rate. Like, you have to treat it by patient to patient, see what's best for that particular patient, considering drug interactions, whatever else they're on, comorbidities, and then going to that. I think that too often it's just, yep, Affirm, rate, and then go rhythm if you can't do rate. So just something to consider.
And as far as her anticoagulation goes, we forgot to mention that there is one integral part of deciding whether you're going to anticoagulate or not is the CHADS VAS score. So I won't go too in depth on that, but essentially it's an acronym stating risk factors for stroke. One of those being a history of previous stroke, which she now has, which gives her 2 points. So 2 points
automatically
is
anticoagulation.
Automatic anticoagulation. If you have 1 point, you can make a decision towards anticoagulation or not. You can choose aspirin or anticoagulation. If they're low bleed risk, I know a lot of people are going to choose an anticoagulant, like warfarin or a NOAC. That being said, women have to have a score of 2 because being sex category is the SC at the end there, and being female automatically makes you higher risk of having a stroke. So that gives you 1 point. So does that mean all females are going to be anticoagulated? No. So if their only risk factor is being a female, then the recommendations are they don't have to have anticoagulation necessarily. So I think the recommendations are you'd have to be a female, then have an additional risk factor, and then you're automatically anticoagulated.
Yeah. Being a female is not a modifiable risk factor.
Well,
that
it
might be a
depends who you
little
talk to.
offensive. So that's definitely a good point. I'm glad you brought that up, Cole. That's solid. So the other thing is too, if we were going to keep this patient on warfarin, they started to put her on heparin and then discontinued it at discharge. One thing to consider now, the reason why a lot of times they bridge with either heparin or enoxaparin when you're giving warfarin, the thought process behind it is basically the warfarin is vitamin K dependent clotting factors, and so all of those clotting factors will start to downregulate because you're blocking the vitamin K receptors. But you have your natural anticoagulants, your antithrombin, your protein C, protein S. All those get wiped out first because they have a shorter half-life, and so you're actually in a hypercoagulable state at first, and so they bridge with enoxaparin or heparin in order to get you to a therapeutic INR and then take you off. This lady, though, however, is because she's got AFib, the bridging really only becomes a factor when it's a DVT, VTE. You don't have to necessarily bridge in this patient with warfarin, so it's not necessarily recommended to do it in patients with AFib. So that's probably why they went ahead and stopped that as she was leaving.
Right, and with DOACs like Xarelto and Eliquis,
You're
you
instantly-
definitely don't have to bridge. It's essentially instant anticoagulation within matter of hours.
So for this heparin 500 that she's on inpatient, was this just VTE prophylaxis?
They didn't really say, and so I don't know.
You would assume though that's the prophylactic dose,
Yeah.
5,000 units Q8. So I think that's a safe assumption.
So if someone comes in and you put them on this heparin prophylaxis and they need to go back to warfarin, will you still use your bridge therapy, heparin to warfarin, and
In the
this sort of
setting of like a
situation?
DVT?
I'm sorry?
In the setting of like a DVT where you would need to bridge?
No, like in this setting where we have, ischemic stroke.
Mm-hmm.
Yeah, probably not in this because it's usually, like I said, usually only used in DVT. But again, I don't deal with this enough to say there may be cases where the cardiologist does want them on that. So that would definitely be something that we would have to get cardiology to consult on.
Right. Maybe if they were like super high risk of recurrent stroke within that time frame, maybe they would want them to bridge. But I think like the general recommendations, you don't have to, but it's patient specific.
Yeah. The other thing is a lot of times they'll start warfarin a week or two later, so that you reduce the risk of it converting over to a hemorrhagic stroke.
Mm-hmm.
So they stay on aspirin 325, and then they come off that in 2 weeks when they start the warfarin. So the way her discharge was written, it kind of looks like they're starting aspirin and then starting warfarin at the same time, which would be unnecessary unless she, had stents placed or something like that.
Right. So if she had some type of coronary artery disease, like a stent, that's when you would consider extra antiplatelet coverage. But since she doesn't, it's just AFib. The anticoagulation essentially covers her for both AFib and the history of stroke.
Yeah. The other thing that's kind of interesting is the atorvastatin 80. They started her on, and then stopped it as they discharged her. Cole, you want to talk about Sparkle?
Sure. So the Sparkle trial was essentially patients post-stroke who were started on high-dose atorvastatin 80 versus placebo, and the outcomes were good. They wanted to see if aggressive lipid-lowering therapy would reduce rates of stroke.
Recurrent stroke?
Reduce rates of recurrent stroke, right? Secondary prevention. And it did. And it reduced rates of stroke, and it also reduced rates of major cardiovascular events in patients who didn't have CHD. So that's good.
And the other thing is, too, it did that in an ischemic stroke. So hemorrhagic stroke actually was a little bit bigger chance of bleeding. So it's ischemic stroke specifically that you're looking for a Torva 80. So I don't know if she's having, maybe she's having side effects or something with it. I don't really know the reasoning for the stopping, but she still technically would be a candidate for the atorvastatin. It doesn't have any drug-drug interactions with what she's on.
Right. And just so y'all know, the number needed to treat to reduce an event in that trial was 53 over about 5 years. So that's a pretty good number needed to treat.
Yeah. Have we covered everything? So real quick, the calcium carbonate that she's on, this is just a kind of a tiny side note. She's on 600 milligrams, 2 tablets. When she came in, she was on 2 tablets a day. She needs to separate that and be on 600 milligrams twice a day. You can only absorb about 600 milligrams of calcium at a time. So if you have somebody you're putting on like 1,200 milligrams, it's probably a waste. The other thing is the vitamin D. She is getting elderly. Her kidney function looks good, but she definitely probably should be evaluated. Get a vitamin T or a vitamin T.
Vitamin T. That's the new vitamin.
That's the new vitamin.
Came out in 2018.
Yeah, you heard it here first. Vitamin D level, and make sure that she's not deficient in that. And then if she is, possibly seeing phosphorus, parathyroid, all those labs to make sure something else isn't going on.
Yeah. What if both of her levels are good? Does she need it?
If what?
If her vitamin D and calcium levels are good, what do you think?
I think if her vitamin D is fine as well, then that's not a big deal. If her kidney function's fine, I think if her kidney function's low, or the GFR is low and the vitamin D is low, the calcium is normal, that she may be having like renal osteodystrophy and breaking down some of the bone and getting the calcium from that. So I would definitely pull parathyroid hormone and phosphorus things.
Sure.
Labs at that point.
Yeah, there's a little controversy over the benefit of like just sticking everybody on calcium and vitamin D when they're postmenopausal and that sort of thing. But I don't know the answer, so if y'all do, let us know. I did want to bring up quickly. So her blood pressures are pretty soft. Let me tell y'all what it is for those who do not have the case up, but her most recent ones were like 110 over 69, 110 over 71. So pretty soft. That might just be because she's in the hospital for whatever reason. But let's assume that she had hypertension. Or even if she didn't have hypertension and she could tolerate it, there are some good medications that you can put patients on post-stroke that we have some good data behind. One is from the SHEP trial. There's chlorthalidone. Low-dose chlorthalidone reduce rates of recurrent stroke. There's also the Progress trial. That was a combination of an ACE and a thiazide. It was indapamide was the thiazide-like diuretic in that trial, and perindopril was the ACE. And so the combination of an ACE and thiazide reduced rates of recurrent stroke. So that's the Progress trial.
It was the only combination.
Right. So they separate. It was perindopril plus or minus indapamide. So some patients only had perindopril. They separated them out at the end. The perindopril group didn't reduce rates, but the combination did with a number needed to treat of like 17. So that's pretty good. So the Progress trial, it showed benefit in patients who were diagnosed with hypertension and patients who were pre-hypertensive, didn't have hypertension, which is why the guidelines actually say if they can tolerate it, even if they haven't been diagnosed with hypertension, go ahead and get them on either a thiazide, less hydrochlorothiazide. We won't talk about that now. Or an ACE plus a thiazide. Yeah. That being said, the mean blood pressure in the pre-hypertensive group was 136, which if you listen to podcast episode 1, that's actually considered
technically high blood pressure.
Right. Now. That's high blood pressure
now
because she had a history of stroke, which means she has clinical ASCVD.
Yeah.
She has hypertension. So that's a consideration, but I thought those were interesting and maybe could be a consideration for her depending on what her blood pressure is going forward.
Yeah, I'm a big fan of indapamide. It also should benefit in patients 80 to 100 years old in high vet, but it's got calcium channel. I don't know if you said this already.
I didn't.
It's got calcium channel blocking properties as well as being a thiazide diuretic. So I'm a big fan of that one, and it's on the $4 list. So
yeah,
hint,
cheap
provider in the room.
Yeah, buddy.
But the last little thing we'll end on this is she does have osteoarthritis. So I'll just mention this real briefly. She's on Tylenol and it seems to be controlled. If it wasn't controlled, this would be somebody you have to be really careful with as far as NSAIDs, obviously, for blood pressure. Now, one of the questions would be whether or not we could use Celebrex, and some people may point to the data from the Precision trial from last year and a half ago, something like that, that compared the Celebrex to naproxen and ibuprofen, and it didn't show any, because the worry was that Celebrex had cardiovascular risk, especially in patients that were already at risk. And so the patients with either osteoarthritis or rheumatoid arthritis, at the end of the study, there was no definitive risk amongst the groups, and they said that Celebrex had better GI side effects. So the only issue I have with that is naproxen also didn't have any cardiovascular events. It actually had a little bit better pain reduction, and the side effects that were, because they lumped everything in and said serious GI side effects. If you actually look at the supplemental data, the only side effects in the GI system were, I think it was constipation and then iron deficiency from a possible GI origin. Those are the only two, but like bleeding and all those things like that were not significantly different between the two. And the other thing is the Celebrex dose that was used in the osteoarthritis group was probably a little bit lower than we typically would see. Rheumatoid arthritis was a little bit more, but they were grossly underestimated in the study as far as the patient populations. I think it was like 95% to 5%. But I'm a little hesitant to believe that because the meta-analyses, things like that, have showed us that there's a potential risk still with Celebrex and cardiovascular disease. I still possibly would lean maybe towards naproxen if I had to. But I would also maybe look at using topicals with this lady, like capsaicin, to deplete substance P in the hands and hopefully help reduce some of the inflammation.
Or even like Voltaren gel, maybe.
Yeah, even Voltaren gel. Topical NSAIDs would be great.
Awesome.
So
cool. I did just want to make a small disclaimer before we finish up this case. So if you were listening really closely at the beginning, you may have heard reference to the patient having a heart valve replacement or having diabetes. We're going to pretend that she doesn't, just for the sake of time.
Yeah.
We
originally, when we made this case up, we originally made this like way longer than we thought it was going to be, and we're already like well over an hour. So,
but thank you for still listening.
Yeah.
If you're still here, we like you. Thank you.
Yes, and not unless you're making fun of us, then we don't.
No, I still like you. It's okay.
Steve, man, thank you so much for your time. I know you're super busy. It's Friday night, and you're hanging out with us. I love it. Could be out goofing around partying instead, talking about meds. I think it's Friday night, right? It's Friday
night.
It Friday? Yes, I think it is.
Is it Friday?
I've completely lost track of my days.
No, so glad that you guys invited me in. It's really cool. Love what you guys do and love learning, and keep doing what you're doing.
For sure. Thanks for coming on, man.
So make sure you check them out if you're on Instagram. And if you're a pharmacist, it's a pharmacy student, please do me this favor, especially if I've provided you any sort of value in my content. Please go follow him at Paige the PA. I promise you he will give you value as well, and you can definitely learn a lot. Like we said throughout the whole podcast, we really want to encourage interprofessionalism. So go reach out to your PA colleagues and make some friends. Steve, anything else you want to say, or anything else? How else can people contact you if they need to, or you want them to?
I mean, I have a little website. It's nothing fancy, but I've got some contact information on there. It's just pagethepa.com.
Nice.
Pretty standard. Yeah, come say hi. I love reaching out and meeting new people from different professions and disciplines, and I think it's one of the best ways to learn is just to chat and do things like we're doing right now.
Heck yeah.
Hanging out on a Friday night talking about meds.
Sounds good, man. Well, thank you so much for your time. We'll catch you next time.
All right, guys. Thanks.
See you, bud.